Thank you, Ethan, for your kind introduction, and thank you, Jim, for inviting me. It's always a pleasure to come and talk to you guys. I feel like nobody shares my passion of prostate cancer as much as you guys all share that. Um, I'm going to try something new today. Being a surgeon, I always talk about surgery and focal therapy and surgical management of prostate cancer. But this has been a relatively newer interest of mine for last couple of years, and I trained at it with seeing metastatic patients in our medical oncology rotation when I was a fellow at NIH. So that gave me a little bit more background than most surgeons would have of metastatic patients. And this was one of my part of the personalized prostate cancer program we tried to establish at UC. So when I came here 3 years ago, none of these boxes were there. And I wanted each patient to be treated differently depending upon their stage, depending upon their functional status, depending upon their aggressiveness. So we started with prostate cancer multidisciplinary clinic 3 years ago. Slowly, we added focal therapy program for prostate cancer, and we have since treated close to 50 patients with focal therapy, which is probably highest in the tri-state area. And then we added cancer survivorship. We started clinical trials for prostate cancer. And more recently, we added an advanced prostate cancer care program where we take patients with metastatic prostate cancer and provide them treatment based upon the guidelines and provide a more comprehensive treatment than just, a shot of Lupron, which a lot of metastatic patients in the community get. So let's start. These are the objectives of my talk. I'm going to try my best to make it very simple so that everybody is at the same level and understands these terms. So we all know prostate cancer is the most common non-cutaneous, non-skin malignancy in men. This year, we are estimating it's going to cause almost 200,000 prostate cancers in the US. And the mortality rate, the death from prostate cancer, has been rising for the last 2 years. And this has not happened in the last 30 years since PSA screening came along. But if you remember, in 2012, we stopped routinely checking PSA for patients, for men. And some men were getting it, other men were not getting it. So over the last 2-3 years, we have been seeing more metastatic prostate cancer, more advanced prostate cancer than we were seeing before. And that's why the death rate is going to be higher for next 2-3 years. And it's probably going to go down again in 2-3 years from now. Okay. We know prostate cancer affects 1 in 9 US men. So it's a very common cancer, and that's why while there's always a saying that most people would die with prostate cancer than die of prostate cancer, but still a significant number of men die from prostate cancer, close to 30,000 every year. And we have not decreased that number significantly. We have definitely lowered that number some in the last 20-30 years, but it has not decreased significantly because I think there's some questions regarding prostate cancer that still need to be answered. So what is metastatic prostate cancer? I'm pretty sure this word, you have heard this word at some point. So it is cancer that has spread to other parts of the body. So cancer limited to prostate is called localized prostate cancer. Cancer outside the prostate in the lymph nodes, in the pelvis is called regional prostate cancer. But once the cancer goes to lymph nodes outside the pelvis into the belly or into the bones or the liver, lungs, and other organs, that is called metastatic prostate cancer. So once a patient has a metastatic prostate cancer, because it's already out of prostate, it's an incurable disease. And at that point, our target of treatment is not to cure patients, it's more about maintaining the quality of life, prolonging the life, and decreasing the suffering, right? And that's what this talk is about. So, what are symptoms of metastatic prostate cancer? A lot of patients present with urination symptoms. They'll have some sort of urination symptoms. We know that urination symptoms can also be seen in patients with benign enlargement of prostates without cancer. But patients who have metastatic prostate cancer, their symptoms are worse than people who have benign enlargement of prostate. And those symptoms could be painful urination or going to bathroom too often, not being able to empty, urinary retention, having blood in urine. In advanced stages, prostate cancer can grow and block the openings of both kidneys, putting these patients into kidney failure. Since the disease is affecting their entire body, it can cause weakness, fatigue, loss of weight. But the most morbidity, the most concerning complications from prostate cancer comes with the involvement of bone. Prostate cancer spreads to the bones, and it can cause pain in the area where the cancer is. It can cause weakening of the bone and cause fractures. If it causes fractures in spinal cord, it can cause compression. If vertebra, it can cause compression of spinal cord, and patient can lose all the function of the legs. So those are more advanced presentations of metastatic prostate cancer, which we see very rarely, but we still see it several times a year. So treatment for metastatic prostate cancer, as we discussed, surgery and radiation therapy, these are the standard of care for localized prostate cancer. Majority of men with prostate cancer who are not candidate for active surveillance will end up choosing one of these two treatment options. But when we are talking about metastatic prostate cancer, the disease is already out of prostate, and surgery and radiation for prostate is not going to help. And that's why the treatment for metastatic prostate cancer is a treatment which affects your entire body, affects the whole body, and it's called systemic therapy. And there are of three types of prostate cancer. One is called hormone therapy, and it's the most common treatment we use for metastatic prostate cancer. Hormone therapy involves adding or deleting a hormone, right? As the name suggests. The second is immunotherapy. It's very commonly used now in kidney cancer, bladder cancer, melanoma, head and neck, and other sorts of cancer. These treatments build up body's immune response against the cancer and makes body fight cancer more effectively. The third is standard chemotherapy, and which has been around for now decades and decades. These are drugs which are toxic to cells which grow rapidly. Cancer grows rapidly, so these drugs preferentially kill cancer cells. Okay. So before we jump into the treatment, let's discuss androgen production in men. Androgen, like testosterone, are male hormones. These are the hormones which are responsible for developing sexual characteristics in men, mustache, hair, beard, and results in our men being muscular, having libido. So these hormones are responsible for all those functions. These hormones begin by stimulus from the brain, from part of the brain called hypothalamus, which stimulates another part of the brain called pituitary, which then releases a hormone called luteinizing hormone, and that then stimulates the testes. And the testicles secrete testosterone. The other organ which is responsible for hormone secretion, androgen secretion, is adrenal glands.
Yeah, I think I would be fine.
I think somebody's talking.
Let's all mute our computers, okay?
Okay. Sorry, I got a little bit distracted.
Okay.
So testosterone is a male hormone. Androgens secreted by adrenal glands sitting on top of kidney are the male hormones. Why are we discussing male hormones? Because these hormones are food for prostate cancer. Okay, they are necessary for prostate cancer to survive. And when the cancer is already out of the prostate, we can control cancer by taking these hormones out of the body and starving the prostate cancer. Okay, that's the first treatment for prostate cancer. And based upon that treatment, prostate cancer can be divided into two categories. One is the term called castrate sensitive versus castrate resistant. So what is castrate sensitive? Castration sensitive is a kind of prostate cancer which will respond to removing testosterone from the body, which can be starved by removing the testosterone. And that's the first treatment. Once the cancer responds, a couple of years later, it stops responding to that treatment, and then it becomes castrate resistant. So it can grow, it can survive even when there's no testosterone. But most prostate cancers would be castrate sensitive when they begin. This is the natural history of prostate cancer. Patients get diagnosed with cancer in the local stage most of the time, and then they get treatment, radiation or surgery. PSA comes back. Some of the men, when the PSA comes back, they don't have any symptom of prostate cancer because there's no obvious prostate cancer. Some of the men then end up getting hormone therapy, others don't. Eventually, a significant proportion of men will become metastatic, means they will see obvious signs of cancer in other parts of the body. Then they respond to the hormone therapy for some time, but then the PSA starts rising back up, and then they'll need more toxic treatments like chemotherapy, and that responds to some degree, and then eventually patients will die. So that's what castrate-resistant prostate cancer means, that the cancer which has stopped responding to the hormone therapies. So what constitutes hormone therapy for prostate cancer? There are three ways to manipulate prostate cancer by using hormone therapy. The first is reducing the production of testosterone by testicles, reducing androgen production. Second is by blocking the action of testosterone. Now, in the second mechanism, testicles are producing the same amount of testosterone as in any normal man, but they are not being able to act on prostate cancer. So they're not being able to provide food to the prostate cancer. And third is blocking androgen production completely through drugs which change the molecular mechanism in the cells. And that androgen production means androgen both in the testicle and in the adrenal gland. So how do we remove testosterone? The simplest method is orchiectomy, removing both testes. And that's called surgical castration. It's a one-time procedure. It's cost effective because it's one time. But the side effect is it's invasive. It's a surgery. Patients have to go under anesthesia, and it involves incision, and there's risk of bleeding and damage to the surrounding structures, problems with anesthesia. But it's very cost effective and very effective for the cancer control also. The second method is medical castration. And for this, we use drugs which are LH-RH agonist and antagonist. LHRH, the full form is luteinizing hormone releasing hormone, and we'll discuss in the next slide how it works. It's an injections, either subcutaneous or intradermal, depending upon the formulation, and it's given 1 to 6 months. It's more costly in long term, but the advantage is it's just an injection and it's non-invasive. So how do these drugs work? As we discussed on the earlier slide, that the portion of the brain responsible for testosterone secretion is hypothalamus and pituitary. So these drugs act on the pituitary and initially stimulate, but eventually they decrease the production of luteinizing hormone from the pituitary. Since there's less luteinizing hormone produced by the pituitary, the testosterone production by testis decreases, and patients achieve castration, and that's called medical castration. Regardless of how we achieve castration, be medical or be surgical, it has a lot of side effects. Some patients experience these side effects more than other patients. Some patients are miserable, while a significant proportion of patients don't feel anything. But the most common side effects are related to what the functions of testosterone. So testosterone is responsible for libido. If there's no testosterone, there won't be libido, loss of interest in sex. It causes impotence. One of the most bothersome symptoms is hot flashes. Testosterone is responsible for bone density, and when there's no testosterone, the bones get weaker and there is some risk of bone fractures. Men lose muscle mass. There are other changes in their metabolism which are not beneficial, like increasing lipids and insulin resistance and weight gain. The other side effect which bother men significantly is fatigue. They feel very tired. They feel they don't have any energy because testosterone is responsible for our feeling of energy. So I tell my patient when they ask about the side effect, it's like male menopause. By giving these drugs, we're essentially putting men into menopause, and they have all the side effects as a female would have when they have menopause. But this was a treatment for prostate cancer for 20, 30 years. In early 2011, 2012, we started to get more drugs for prostate cancer treatment. And it started with combining ADT with a chemotherapy drug followed by other drugs, which we're going to discuss in the next few slides. But now we know from all the data and literature that patients who have prostate cancer outside their prostate, just giving a shot of ADT, shot of Lupron is not sufficient. The data shows that patients who have metastatic cancer, if we give them just the treatment which we just discussed, their chances of becoming resistant to that treatment is only 9 months if it's a high volume disease, and it's almost 2 years if somebody is low volume disease. But most men will become resistant to this treatment within 2 years if we just give them the ADT. And that's why we need to now combine ADT with some newer drugs, which just came into picture in the last 4 or 5 years. And those drugs are called antiandrogens. Now, antiandrogens have been around for a long time, but the newer antiandrogens are better, and they have been shown to be effective in combination with Lupron. What they do is instead of decreasing the production of testosterone, they actually block the action of testosterone. So this is testosterone, this is prostate cancer cell, and testosterone is acting on the prostate cancer cell. And what ADT will lower the testosterone, but the amount of testosterone which is being produced will still act on the prostate cancer and still lead to growth of prostate cancer. Antiandrogens will block testosterone from acting on prostate cancer. So it's kind of taking away the minimal food they have and now letting prostate cancer have that androgen. One of the first drug which came into the market, which was newer antiandrogen, was enzalutamide, and the trade name is Xtandi. What it does, it blocks androgen receptor and doesn't let testosterone do its job. Testosterone promotes the growth of prostate cancer by some complex mechanism in the cell. This drug prevents it from happening. So even though there is only small amount of testosterone, this drug prevents that small amount of testosterone from acting on prostate cancer cells. It makes the side effect of androgen deprivation therapy even more worse. Patients complain of more fatigue, they have more hot flashes, they complain of muscle pain and diarrhea, but the side effect which stood out is seizures. It happens very rarely, less than 1% of the cases, but that side effect was not seen with androgen deprivation therapy alone. But when you combine this drug, you'll see that happen rarely. This drug can be given in both castrate sensitive and castrate resistant setting. The second drug, which is one of a very effective drug, and I use it very commonly, is called Abiraterone. And the trade name is Zytiga for this drug. This drug is an antiandrogen because it inhibits production of testosterone everywhere. And it acts at a molecular level, acts on enzymes in the cell, prostate cancer cell, and adrenal cells and testis cells, and blocks the androgen production everywhere. It has to be given in combination with androgen deprivation therapy, and it can be given in both castrate sensitive and castrate resistant prostate cancer. It increases the side effects, same side effects, but patients have more severe fatigue, more severe joint pain, more severe hot flashes, but it also can cause retention of fluid and can also cause liver dysfunction in a small proportion of patients. So those were androgens and anti-androgen therapy. All those drugs were part of hormone therapy. There are other couple of new drugs which have come up in last 2-3 years. One of them is apalutamide, Erleada, and their newer drug coming from Bayer, which act in a similar fashion. Only the side effect profile is different for each of these drugs. So the next line of treatment is immunotherapy. Now, immunotherapy is very popular, as I discussed, in other cancers like kidney cancer, bladder cancer, and is almost becoming a first-line therapy for these cancers because of effectiveness. Prostate cancer is not very immunogenic. The immune therapy is not very effective for prostate cancer. And there have been trials which have not been shown to be very, very effective. There are only 2 approved immune therapies for prostate cancer. One of them is Provenge or Spilocel T. This is an immune therapy in which patients' resting immune cells are taken from by drawing the blood. Those immune cells are then transported to a special lab where those cells are then activated against prostate cancer cells. And that treatment is called Provenge. And that treatment is then injected back to the patient. And these cells, which are now activated immune cells, they multiply and they find prostate cancer and attack prostate cancer because they've been activated to attack prostate cancer. Most patients don't feel very significant side effects. They get flu-like symptoms like chills, fevers, fatigue, joint pain, but it's a very well-tolerated treatment. It's a treatment which is given in 3 cycles, and it's just an infusion, outpatient infusion. It's only used in patients who have castrate-resistant prostate cancer and when they don't have much symptoms. It's not a useful treatment when the cancer is already very advanced and patients are having a lot of problems. It's only used on the early part of the metastatic disease. The other treatment which is approved is called Pembrolizumab. It's the class of the drug is called checkpoint inhibitor, and it also activates immune response against prostate cancer. It's approved for very specific genetic mutations in prostate cancer. It's not approved for every single prostate cancer patient, but patients who have specific genetic mutations like microsatellite instability or DNA mismatch repair, those patients will get some benefit by pembrolizumab. Again, it's a second line therapy, so it comes way down the order compared to other therapies for prostate cancers. And the reason, as we discussed, prostate cancer is not, immune therapy is not very effective for prostate cancer. There are some failed attempts for prostate cancer, like nivolumab was tried. There was a vaccine called ProstVac, and that was not effective by itself, and now has been tried in several combinations. And people are hoping that it might be more effective in a combination, but it was not effective by itself. Okay. And the third treatment, and this is usually the late stage treatment, is chemotherapy. As we discussed, chemotherapies are the drugs which are toxic to the cells which divide rapidly. And since cancer cells divide rapidly, they multiply rapidly, they are most sensitive to chemotherapy. Docetaxel is the most commonly chemotherapeutic drug used for prostate cancer. It limits the multiplication of fast-growing cancer cells, resulting in cell death. This drug has been shown to improve prostate cancer survival. It leads to improvements in pain and quality of life for prostate cancer patients. It's used both for castrate-sensitive and castrate-resistant setting. The side effects of chemotherapy is definitely way more advanced, more severe than the side effects of androgen deprivation therapy or immune therapy. Patients get a lot of nausea, vomiting, they feel very fatigued, and it can also cause to decrease in the blood counts, leading to infections or bleeding. Usually we reserve these treatments for young, healthy men who can handle these toxic treatments, or sometimes as a last resort when nothing else is working. Another chemotherapy drug is Cabazitaxel, and it's approved in castrate-resistant prostate cancer after they have already failed Docetaxel. So way down the line, when almost all other treatment options have failed. Okay. So those treatments all work on prostate cancer cells. But as we discussed in earlier slides, one of the main cause of morbidity from prostate cancer is its involvement of bones. That causes the most morbidity and decreases the quality of life for our patients. Normally, there's a process called bone remodeling, which is going on all the time. It's a balance between bone resorption and formation. So the bone is getting resorbed by the body and the new bone forms all the time. When that balance gets disrupted, patients can have weakening of bones and fractures. And prostate cancer metastatic disease disrupts that balance, causing weakened bones, fractures, and pain. Not just cancer, even the treatment for prostate cancer, androgen deprivation therapy, does the same thing. Since it's kind of inducing menopause, it can decrease the mineralization of our bones and can cause osteoporosis and risk of fractures. Skeletal related event is one of the things which clinical trials for prostate cancer mention all the time, and that is either bone fracture, spinal cord compression, or any bone condition requiring surgery or radiotherapy. And a lot of prostate cancer patients towards the late stages will have bone involvement. And if those bones are not taken care of properly, these patients will develop pathological fractures and get surgeries for hip fracture or other fractures in the body, because the bone has been weakened either by the treatment for prostate cancer or the prostate cancer. So the drugs used to treat bones have been classified into two categories. One is the drug category used to prevent bone loss. Okay. The other is to treat bone cancer coming from prostate. And these are the three drugs listed in each of the categories. So let's discuss denosumab, which is very commonly used drug. And it's an antibody which prevents bone resorption. So prostate cancer results in bone resorption results in weakening of bone, and this prevents prostate cancer from doing that. It is given both for bone metastasis and also to prevent bone loss. Higher dose for cancer, lower dose to prevent bone loss. It has been shown to decrease the fractures, but it doesn't make patients live longer. It just prevents them from having bone fractures and other bone issues. Usually very well tolerated. Patients don't complain of much side effect from this drug. It can cause flu-like symptoms, decrease in calcium, in blood calcium. One of the most dramatic side effect, very rare though, but very dramatic side effect is necrosis of jaw in patients who are getting dental treatment and this drug. So if patient has a cavity or some sort of bad tooth infection, because they were getting these drugs, sometimes patient can get just the jaw being completely dead and resorbed because of this drug. So that's a very dramatic side effects. And we check our patients, we make sure our patients have healthy teeth before we start them on this drug. Another drug similar to denosumab in action is zoledronic acid. This is an old drug and it binds to calcium in our bones and prevent bone resorption. It also decreases in SRE, skeletal related events, and similar to denosumab, it has no increase in survival. So patients don't live longer, but they have better quality of life because they don't have fractures and bone pain as much. Side effect profile is similar. So radium-223, or the trade name is Xofigo. This is an agent which acts on bone and actually cures prostate cancer, takes care of prostate cancer. It is a radioactive agent and it seeks bone. It's similar to calcium. So wherever calcium goes, radium goes there. So if there's some activity in the bone where the bone is getting resorbed or the new bone is being formed, the body requires calcium to do that. And since radium is similar to calcium, radium goes to the same location where the calcium is. So since cancer cell leads to this activation of bone recycling, radium goes there and releases these radioactive agent alpha particle and kills the prostate cancer cells. It has shown to decrease fractures, bone pain, improves quality of life, and it has also been shown to increase survival in these patients. So this is the only bone agent which can actually make prostate cancer patients live longer. It's approved only in the castrate-resistant setting when patients have symptomatic bone disease. Okay. So to summarize the treatment from NCCN guidelines, we've briefly gone over the agents, and I'm pretty sure that was very heavy information. I'm just going to summarize the names for these agents. So when patients are being diagnosed with metastatic prostate cancer, they should either get ADT alone, which is now not a recommended treatment. It's more a category 2 treatment. But the category 1 treatment is ADT in combination with either the chemotherapy, Docetaxel, or ADT in combination with Abiraterone, ADT in combination with Ablation, Enzalutamide. In some cases, you can consider giving them radiation to the prostate. And so these are the treatment options for patients newly diagnosed with metastatic prostate cancer. When the cancer is not responsive to the androgens, then they can get these treatment options, which are similar, but they're more second line. If they've already gotten Abiraterone, then for the second line, they'll get something else. And these are the options divided based upon what was their first line option. If the first line was Enzalutamide or Abiraterone, then they'll get chemotherapy up front. If the first line was chemotherapy, then they'll get Abiraterone after that. Okay. So this is something I want to share as a part of our advanced prostate cancer program. There are several other trials we have, which are only systemic therapy trial, but this is a trial which is a surgical trial in this setting. As we discussed, when patients have prostate cancer outside the prostate, surgery for the prostate is not standard of care. We don't have evidence that that'll help. There has been retrospective studies showing that surgery might help in patients who have cancer outside the prostate. There is a trial which showed, it was not the primary aim of that trial, but a secondary aim of the trial showed that radiation therapy can help in patients who have metastatic prostate cancer. So this trial is a cooperative group trial. So a lot of centers in the country are running this trial where the metastatic prostate cancer patients are being offered surgery or radiation therapy for the prostate versus standard of care treatment, which we discussed earlier, which is androgen deprivation therapy. And then these patients are followed up for the rest of their life to see if surgery combining with regular therapy for prostate cancer, metastatic prostate cancer, will make them live longer or not. So this is the schema for this trial. When the patient signs up for the trial, they're started on a regular treatment for prostate cancer, which is androgen deprivation therapy. And then at 6 months, if they have not gotten worse, if they have not progressed, then they are randomized to 2 arms. One arm gets the same treatment as they would have gotten without clinical trial. The other arm gets same treatment plus either surgery or radiation based upon patients' and physician's preference. And then both arms are being followed for up to 8 years. Okay, thank you.